Okay, well, my name is David Armstrong. I'm the director of the Health Workforce Tactical Assistance Center. Welcome to our virtual meeting. This is the fourth in a series of meetings about, nursing education challenges, I guess, for a better word. And in this meeting, we have Becky Wiseman. This is we're kind of also celebrating her retirement here in the next couple of weeks. So we can call this a
We won't go too deep into that.
She's going to give you her words of wisdom from her career. Is that how that works? And we're also joined by, and Rebecca's out of Maryland. And we're also joined by Diane Hountz. Is that correct?
Yes. I have
to thank you, Diane Hountz. And Diane's out of Lafayette, Indiana. And so with that said, I guess that was somewhat informal of me. I could put up like a screenshot or what have you, but I don't think we need to do that. We're here, so let's chat. I hope you enjoy the conversation, everyone. And by all means, thanks for coming. Becky?
So our idea when we decided to do this discussion group was to talk about the challenges and the good pieces too of being a faculty member. And it is a challenging environment to be a faculty member and to be a nurse and to maintain practice. And so that's what we want to talk about today. We don't have all the answers. We don't have any of the answers, but really we wanted to talk about what it's like to be a faculty member and how we can encourage other people to want to be faculty members. So I did a quick little lit review looking at how do we retain our nursing faculty, because as you know, there's a nursing faculty shortage, just like there's a nursing shortage across this country. And some of the things I found on a quick lit review was one of the things that's really highly recommended to keep faculty is that they have a good orientation when they come on board, that they actually, and this has happened to all of us probably somewhere along the line, we get hired and the next thing we know, we're in charge of the course and we're running the course and we're setting up the conicals and we're doing all those things and we're sitting there going, whoa, wait a minute, I didn't have time to breathe, that type of thing. So one of the things that really helps to retain nursing faculty, is to have a good orientation period. And it's recommended about a year that people have an orientation where they have an assigned mentor, someone to work with. They actually have a reduced teaching load and have someone to work with them as a mentor to help them, not do what some of us have done to us, get thrown in and you're in charge of the course and no one to ask questions and you're trying to figure it out. And then the other thing that's really helpful, because as you all know who are faculty members, it's not just teaching our nursing knowledge and practice. It's really about being a member of academia. It's being a member of the academic community. And so when you come on board as a faculty member, there's that whole organizational thing where you have to think about promotion and tenure. You have to think about scholarship. You have to think about research. You have to think about your career trajectory in the academic world. And so some places are putting in place it's like the Boyer model. If you're familiar with the Boyer model, the Boyer model is a model of scholarship, where you also have emphasis on your teaching, your practice, your service, all those elements, instead of, like, I'm at a level 3 top tier research institution, University of Maryland. The focus at our university is on research and getting the NIH grants. And so we have recently, within the last 5 years, been looking at a different APT model where we're looking more at the Boyer things, and we actually have a tenure track based on education versus the research tenure track. It had to go through the whole University of Maryland system approval, but it's just been launched within the last year. And so it's really brought a breath of fresh air to all of us who are not the NIH researchers, because face it, not every one of us is going to get NIH grants. They're very limited. You're just not going to get them. And so how do you then maintain your scholarship and go for your promotion and tenure? So those are sort of some of the things I'm finding in the literature. And then we're going to talk today about some of that. So Diane?
Thanks, Becky. I just wanted to give a little background. I, in addition to working at the Indiana Center for Nursing, I teach at Purdue University as well. So much like Becky, it's a R1 institution. Mm-hmm. So coming kind of from that lens of I'm clinical faculty, but also keeping in mind that promotion and tenure as well. And I would love to hear from everyone. I see, thank you all for putting in the chat where you're from. What type of institution do you teach in? If you do teach, or if you're from practice, what type of practice setting are you in? Would love to hear more about that so we can kind of tailor a little bit more about that. Another thing we want to talk about, one of the things that we tried in our institution was a mentoring program, in addition to what Becky has talked about on some of the best practices and what the literature says about orientation and kind of onboarding faculty. We've had a big focus on that. And we were an institution where I believe it was about 5 years ago, our president said, we're going to double the undergraduate enrollment of your program, and we all jumped up and down and yay, this is going to be a lot of fun, right? But what that included was doubling the faculty as well. And so we really thought, how can we retain the faculty that we've had? So we really focused a lot on onboarding and the mentoring program that came from that. We've had great success with that. You know, I don't know exact retention rates, but that mentoring program really has helped connect one-on-one with faculty. Especially, we have a lot of newer faculty that they're brand new to academia and came either as an NP from practice or as a director, or had a master's in MBA, or or more in a director role in a healthcare center. So they really, you know, it's a steep learning curve. I think those of you who have done it, who've come from practice into academia, it's a steep learning curve, and trying to learn the ins and the outs. You know, we've tried to, that orientation period, my gosh, when Becky said that 1 year, gosh, wouldn't that be great if we all could have 1 year of orientation to the faculty role, right? And I think that that's tough. You know, we all have shortages, so that's been tough for us to do as well. Some semesters we can do it great. Some semesters we're okay. We're here if we have a mentor for you. We're here if we need you. But I think that those are best practices. We all certainly try to attain those and try to keep up with those, but it's tough sometimes. I think I would love to just kind of go in, you know, and to hear from everyone, what challenges have you guys had recently in with either a new faculty role, or are you all in faculty? Are you on faculty somewhere, or are you practicing? It looks like Lindsay is an NP practicing in outpatient cardiology. Great, thank you for saying that.
Well, good afternoon. Hi, everyone. So I am relatively new to academia. I was a practicing NP in transition 3 years ago as a full-time faculty, but I still practice 1 day a week. I think for me, having a mentor was very significant in helping me in my transition. However, in 3 years in, I still feel fairly like a novice educator. So there are a lot of little, I guess, behind the scene things that you don't learn when you take, like I did this certification, the nurse educator certification program when I got my doctorate. So there's still a lot of behind the scene things that you just don't get in those courses that you kind of have to learn along the way. So definitely having a mentor was a plus. The orientation for a year and maybe decreased course load would have been a benefit, because as I was kind of, like you said, learning to be in academia, I also was a course coordinator and coordinating clinicals and courses. And so I had taught clinical before, so I kind of had some idea of how that went, but like pulling all that together and mastering the material for lessons and lessons plans and active learning. And it really was a lot. It was a lot. And I'm just really starting to feel like I'm on solid ground 3 years in. So it's a steep learning curve coming from practice to education. So
Thanks for sharing.
Yeah. Thank you for sharing. That's great. Maybe some of you have been in this role as well. I was a teaching assistant prior to, I was getting my doctorate, and teaching assistant prior to coming on board as faculty. And I was very, very grateful for that toe stepping in a little bit of that. So I had the clinical part down. It was just that other part. But I agree with Bernice. It was even with that, it was a steep uphill afterwards, especially when you're thrown into course coordinating and wowza, a lot of students. So thank you for that. Anyone else want to share?
I see Sharon said she was a clinical academic practice coordinator at a health system, but she has taught clinical. Sharon, have you taught classroom as well as clinical?
Yes, I have. I've taught the nursing health assessment, professional issues in nursing. There was one other one I taught along the way as well. They have an accelerated nursing program. So during COVID, I taught several classes during that. But my main focus has been clinical instructor. I've been there for about 17 years. In addition to working full-time in the acute care hospital, which is part of the health system that I work for. So now I onboard all the nursing students, NP students, a couple of other roles that go in the nursing department. But it's, great to be in, because I know I see a lot of the academic piece and the practice piece. So it's great to sit down with students and talk to them and, get them on the right path.
I think that's so important that students have people that they can talk to and kind of knows what's going on in the academic setting and has some compassion and some empathy for what the students are going through when they come to the clinical setting. So I think that's a good combination, Sharon. Sounds like a good group there. So anyone else? We'd like to hear from you, just your experiences, what you've been doing. We have a few other questions we're going to ask, but we just kind of like to do the intro kind of things. Madison, what are you doing? You're over there in Indiana.
Yeah, I actually work for the Bowen Center, a research institute at IUPUI. So I don't really I'm not clinical. I'm just here for, research and feedback on what you guys think is the biggest pressing issues. And we also know that we're fighting against not only a nursing shortage, but also the teaching shortage on this side of things over here. So we are always just trying to get a grasp on what we can help research and move forward.
Sure.
Based on the ground, real life, experience. So.
Well, some of the school, across the country, I think AAC, which is American Association of Colleges of Nursing, every year does a survey of the schools and asks them how many students who were qualified were not able to be admitted. And we know there's something like 90,000 or more people who want to be nurses who are not able to get into schools. And one of the strong factors about why schools aren't able to take more nursing students is a lack of faculty. There is this definite faculty shortage, and that includes clinical instructors as well as classroom type instructors. But that is one of the big deciding factors as to the capacity to take on more students. Diane, you probably have experience with that. when you said you were going to increase your size of your undergraduate programs.
Yes, yes, definitely. So far we've been able to maintain that and, have faculty openings, but it's, we've not had to decrease our student enrollment because of that. So been lucky on that end, but know many that have had to do that. So, yes.
So Lindsay, what are you doing over there in Massachusetts?
So last year was my first year. Can you guys hear me?
Yes.
Sorry, I've been switching back and forth between my microphones. My kids are down here now. So you don't need to hear them. But last year was my first year teaching. I teach in Springfield, Massachusetts at American International College. I was hired 2 weeks before the semester started and had some great mentors, but had my own course right off the bat. So I came from 15 years of nurse practitioner practice in the busy cardiology practice. I had NP and RN students and everything whenever possible, but was my first foray into teaching last year. I taught nursing research as my first course right out of the gate. And then leadership in the spring for the seniors. So I was the course coordinator on those independently, but with faculty support. And so I, like Bernice said, I'm still climbing that very, very steep hill as I sort of transition. And I still practice 1 or 2 days during the week in my NP role. So that's my story.
And you're sticking to it, right?
I'm sticking to it.
Sean, are you able to join us?
Looks like she's connecting right now.
Yeah. She doesn't have to video if she could just connect with us. I'd like to know what Sean's doing. While we're waiting for Sean, Linda, over there in Illinois, what's going on over there?
Hi, this is Linda in Illinois. I work for the Nursing Workforce Center. I don't have any faculty role or function and have never taught in my life. And I hope to never in my life be a teacher. It's just the way it is. We do have some funding that we're working on with nursing faculty we've had for many years about a salary stipend, and the faculty member can use it for whatever they want. They want to use it for tuition, if they want to buy a new computer or whatever. So we've been able to maintain the funding, I think, since 2007. It's $10,000 a year, so the faculty member receives about $7,500, and you can apply. You have to be, your nomination has to be supported by the head of the dean or the director of the nursing program. And so we have had about 40 faculty the last couple of years, and I think we'll have 80 this year. So that's what I can do. And we've also been able to increase the grants for nursing classes, and a lot of them over the years have done simulation. Those simulation things cost a whole lot of money. And so a lot of faculty have applied for those things because, you can, if you have them, you can do different things. So, but that's that, and working with another department that does the nursing scholarships, we've been able to maintain, I think, the $4 million for the nursing scholarships for about 10 years. And it's primarily for pre-licensure, but it's also for the graduate education it supports is teaching, and it's mostly pre-licensure. So that's it. I have nothing exciting, and sorry about that.
No, but I'm sure, Linda, you hear stories. I'm sure, the things that you hear from people, and that's really great support for people to have that support for the $10,000 a year and for some simulation, because that's important. You have to have the resources to be able to work with also. So we're going to ask you another question. For those of you who are faculty or have been doing faculty roles, what do you wish you knew before you became a nursing faculty member? What do you wish someone had told you prior to actually taking on a teaching role, whatever role you took on, a clinical instructor or actually being a faculty member? What do you wish someone had told you before you got started? What would you have liked to have had the knowledge of?
Well, I could speak to some of this. I find it interesting. When I first started as a clinical instructor, they had sent out an email to everybody to see if they were looking for a clinical instructor for the school. And I said, oh, I would be interested. My next email back was 6 students, and I would be starting on the following Saturday. And it's pretty much never changed. That has been how it's gone ever since. I've never had any type of orientation. So now in my role that I do for the health center, whenever I get new instructors from any school, I don't care where they're from, I go out and I talk to them, because even things as basic as, keeping a roster and when people are out sick, so that you know what's happening on the units is helpful to them, because I find that has not changed. I have been involved with a nursing council that we've just started here over the past year in Massachusetts, and hearing some of these stories, these are some of the things that they're looking to put into place so that, it won't keep happening, and that we will get people to join, faculty, anything, clinical instructors, we need everybody, and make sure they're satisfied and that they have mentors to follow up with them. I was curious about, everybody talks about, how many people have been turned away from nursing schools. But one of the things that we looked at is that every time somebody applies to a nursing program, or any program actually, but the nursing programs that we're always looking at, if they don't get in, that's considered one of those places that's of that 80,000 that didn't get into school. But they may have got accepted somewhere else. And I'm wondering if there's any true numbers to that. Not that I don't think it's an issue, because I do know it's an issue with everywhere that we're looking. In Massachusetts, the Board of Registration and Nursing, this year they put into place that everybody had to do it, but all our clinical instructors have to be master's prepared now. And that has put a real kink in everything. Struggling, the senior nursing students, they have to be with a BS prepared nurse. And with the climate of healthcare, it's just impossible to get those people together. I've come up with a whole program that we do here, where the students come in, they get a different preceptor for the most part every time they come in. But just to get the students to keep coming, because the experience is so lacking when they get out of school now. They're just not getting, COVID took away a lot of the clinical experience, but we've not recovered with any of the programs that they are getting the clinicals that they need to be practice ready. So very interested in everybody's comments on all of these items.
Sharon, following up on what you said about the 90,000 people, it is duplicated. We don't really have a mechanism to know how many schools someone applied to and whether they got accepted somewhere else. All of the reporting is for your school and your admissions, how many qualified people were you not able to take, but wish you could have, based on what your capabilities were. So we don't really know. I know in our state that there are probably 5 or 6 different schools that students apply to prior to, and they may have gotten accepted somewhere else, but we don't have the statistical ability to know that.
Right.
So it's probably an inflated number, but we don't really have a way to capture it. Diane, do you have any ideas on that?
Yeah, I don't think there's a good mechanism to capture that. I know there's software out there, Nursing CAS, that system, but I don't believe they even track that. I think that's where a student can apply to different institutions, but I don't believe they track if they don't go to one institution and go to another.
So. Yeah, that's a good point, because I had I was involved in a similar conversation at the forum just, a couple months ago. Because I can tell you, like in New York, about half the programs, in fact, I just looked up the slide, 46% of the programs in the state turn away qualified applicants. But, a lot of them probably got in somewhere else. You just don't know, though, since there's not that interconnectedness.
And you can't share the information between institutions because the FERPA and all those other confidentiality things. So you really can't do like a cross-reference and say, this person applied here, we didn't accept them. They were good candidates, but we didn't accept them. And the school across the street says, well, we did because they were, qualified. You can't share the data. So it's really hard to get a handle on it. But we do know there are people who are turned away who could be qualified to be. We just don't have a firm number. Bernice, what do you wish you had known before you became a teacher? You said you took the certification for a nurse educator, right?
I did.
So, yeah.
So there's two things. The first is I wish I would have known there was so much committee work and commitment outside of just teaching your classes that is required in education. And I think because I'm at a small school, the burden is higher because the faculty is smaller. So you sit on several committees. So when you're not in class, you're in one meeting behind meeting behind meeting and working, So I think that was something that I was not clear to me. That was a part of the expectation. And the other is that I wish I would have known that the reimbursement for adjunct faculty was so small, because that's another reason that we have difficulty getting adjunct faculty, keeping them. Nonetheless, the master's prepared faculty, because the pay is just very minimal compared to for them to take on extra responsibility above what they do as nurses already. So.
Those are great points. I wish I knew both of those things as well. with that, I'm going to add here, if you all don't mind. I remember my first clinical thinking that I had to know everything, meaning not just as a med-surg nurse, but what was considered a clinical fail or not. If you were going to, so for instance, I had a student who threw a sharps in a trash can instead of the sharps container. And I knew, okay, that's pretty cut and dry. That should be a clinical fail for the day. But there were some other instances where I thought, gosh, is this right? Should I talk to them? Should I not? And we've had several instances recently, and I wish I would have known that I could say to the student, you know what, I'm going to consult our course policies. I'm going to consult our director, and we'll let you know what decision will be made because of your actions or lack thereof actions in the clinical setting. So I wish I would have known to take a deep breath. I didn't have to make a decision right away. And, there was no patient harm or anything, but I wish I would have known that I could consult other people rather than saying, hey, you know what, this was okay. There's not going to be, any repercussions as a result of what you've done. So, and that hasn't happened a lot. I'm not saying that happens every day, when we're out there in the clinical, but sometimes I felt alone and I had to make all the decisions right away. And I wish I would have known that, hey, you can take a little bit of time and get back with the student. So.
There are very few true emergencies in education. And that's the thing that we have to step back and understand, because in nursing, when we're working with clients, there are emergencies and, very important things that have to be done in a time. Whereas in education, as you say, Diane, there is time, unless it's patient harm, that we're able to step back and make sure that we're consistent with the policies and the procedures and everything that one has to follow, because being a student is different from being a clinician. So, it's a difference. Lindsay, you're fresh off the farm on this teaching thing. What do you wish somebody had told you before you started?
So I have to be honest, I don't even know all of the things that I don't know yet. because I'm
I
just
understand.
still so new. So I would walk out of every class and, you know, kind of say, well, I wasn't booed off stage and nobody threw tomatoes. So this is a reasonable place to be. I think that things are somewhat just, you know, the general institutional things that you guys were talking about that, you know, that mentor helps you with. And sometimes, you know, to your point, Diane, I didn't know to ask something because I figured I could figure it out for myself. And so, you know, trying to hunt down an answer independently when, you know, it probably just would have been more efficient for everybody if I had asked something. And, you know, and that's how I run my own, you know, mentorships when I would have people. And that's certainly how I approach the students, you know, please come talk to me if you have something. And I felt very much supported, and I don't know what my barrier was. I don't know if I just felt that because I'd been in practice for so long that there's just this new thing that I'm back to being a novice about. And I wanted to be so independent like I was in practice. And now I am so dependent on people telling me, what is the key code to the copy room again? And just how many times I had to ask that question, you know, before it stuck. And that, you know, so that was a point of frustration, that curve and that complete, you know, switching of going from at least a relative expert to such a novice. And then I taught in, you know, somewhat the abstract courses, right? I didn't teach in the med surge. So I went from, you know, very clinic heavy med surge, pathophysiology, all of the interventions to, well, let's talk about statistics and you know, all of those things. So that was just a big culture shock. So I think just that, you know, reminder of grace for ourselves is probably the biggest thing that, you know, that we need to keep telling our new faculty, that as I sit in a meeting and, you know, people are talking about things and I have no idea, you know, the background because I wasn't there last semester, you know, trying to figure out how to access that back information. And it just, again, circles right back to that mentor that, you know, I had, but I don't think I utilized as much as I should.
I think one of the things that I wish I had known, and I keep falling into it, is taking on those courses where you have a lot of prep. It takes a lot of time to prep to give the lesson, whether you do it online, whether you're doing it in the classroom, or, you know, all the activities that go with some assignment. There's a lot of time up front that you spend prepping. And every time you take on a new course, you're back to square one because you're doing the prepping. But I heard you, Lindsay, because you took on courses like research and leadership that do a lot, you need a lot of prep time. You were probably spending your weekends and Sundays doing that. I always used Sunday afternoon. It was always like 5 hours Sunday afternoon. I was prepping for my class for the week. But I think that's another thing that I hear faculty telling me, because I used to be chair of a department for 13 years. And what faculty would tell me was, I didn't know how much behind the scenes prep I had to do to get ready, you know, for a class. I really thought I could just walk in and impart my knowledge and that it would be all so great, but it really isn't. It's a lot of work. And people come on as faculty members thinking, oh, well, this is cool. I only teach 3 classes and that's only 6 hours out of the week. And you don't realize that you're working 60, maybe sometimes 80 hours a week with all that back behind the scenes stuff and the grading and the assessments and the committee work buddies that you're all doing. That's a lot of extra time. So I think people are shocked by how much time it takes to be a faculty member. Any comments about that, or you're all nodding your heads? I think you all found.
Can I just
that
also
out.
add that as a new faculty person, I'm coming into education, I was really intrigued by I'm going to have summers off.
Yeah, right.
So I quickly found out that that just means you're not on contract, but it doesn't mean that you're really off. So I think that's a misnomer that you are like that you have summers off.
Yeah, you're always getting ready for the next semester while you're teaching that semester. You're always prepping and getting ready. So when you quote have your summer off, you don't really, because you can't walk in the end of August and boom, just walk into a classroom. It takes a lot of prep to get there and get those clinicals set up and everything. So yeah, I think I'm not sure that we are as transparent as we could be for faculty, potential faculty members, to know how much time really is involved. It's the same thing with nursing students. I think when we try to tell them that you may come to class 3 or 4 days a week and you have quote Fridays off, that they think, oh, that's easy. I did that when I was doing my prereqs. And then they realize they've got labs, they've got clinicals, they've got prep time, because if you have one of those interactive classrooms, they've got to prep to get to the classroom. So students often we're often in our offices saying, I had no idea. I thought I could work full time and go to school full time. And so, yeah, it's a lot of behind the scenes times that we probably aren't as clear about. Did you have a question you wanted to ask, Diane?
You know what? I actually was wondering from you all, who it sounds like many of you have had years of clinical experience and now have transitioned at least part-time to a faculty role. What do you feel is important, or how do you keep current in the clinical setting? How do you keep your assessments up to date? How do you keep up with the knowledge that you need to feel clinically competent, or to be able to teach these new learners? Any best practices or anything that you've seen or do that helps keep you current there?
I think I heard a couple of you say that you practice at least 1 day a week. Diane, you practice also, right? Yeah.
Yes. How does that work? Do you guys, is there a contract for those of you who practice as an NP? Do you have contracts with your practice facility and then kind of share time, or is that in addition to, you're working extra?
When I left my practice, I made arrangements with them to come back PRN.
Did you? Okay.
Yeah. So I left my practice to get acclimated, and then for a couple months, and then I started back, and I negotiated with them after speaking with my dean, like what day academically would be a good day for me to be off campus or not accessible. And so we picked a day where it didn't interfere with my course load or other things or our meetings. And so that's my practice day. So I have a practice day that's negotiated with my dean. And then so my old work facility, because they still need clinical help, was more than happy to have me come in 1 day a week and just work that 1 day a week. So that's how I was able to negotiate it.
Good. That's great.
So
Thank you.
I did the same thing. So I'm full-time faculty, and then I do per diem work with my practice. And that gives me the flexibility to say that I have a heavy grading week, or I have a heavy week assisting in the sim lab, and I won't be able to come into the clinical practice setting, but still gives me the ability to then, if I have a lighter week, pick up an extra day. Because as Bernice said, financially, this was a different focus. So summers off maybe isn't summers off, but it's summers home with my kids, doing a little bit of extra, work as I sort of can around them. And then going some days without doing any prep work for the fall. So, that balance and that trade-off. But yes, per diem is how I manage it as well. And then there's other nurses, faculty that work as nurses, and they do the same thing. They pick up per diem shifts. That seems to be the easiest way, at least here locally, to manage both.
I think
great.
from a education perspective, so it's beneficial for you as far as keeping current with what's happening in the clinical setting, but it's also almost a financial need because education, and Lindsay will tell you, the pay cut going from full-time practice to education was interesting to say the least. But like she said, it was a good trade-off for the peace of mind, and for her, it was time with her kids. And so it kind of like you know, you got to do your checks and balances. And so, but yeah, so having that, knowing that you have that ability to supplement your income also is beneficial.
That's great. Thank you guys for sharing that. I know that I've seen different models, and that certainly is one where it's per diem and then full-time faculty. We also I've seen where it's like the practice day. I think Bernice said I have one practice day a week, and we have several NPs that have that built in. And so every Monday is their practice day, and then they adjust their workload for teaching down as a result of that. So, in theory, it's just 40 hours, including the practice day. So the practice day is not in addition to that. And I've seen other institutions adapt some of those models too, where it's part-time work here, part-time here. And, it also is, it's for, all of the things that you guys talked about. It's to help balance work-life balance a little bit, but also with supplementing the income. But we've had a lot of really good success with partnering with just local hospitals and practice sites where they are willing to pay, that part and have them there 1 or 2 days a week. So just another example.
I was inspired by the nurse practitioner that I worked with who got her degree ahead of me. And so she actually has a dual partnership contract because she works for the university that the university and the hospital are under the same umbrella. And so they've partnered out to figure out who pays what percentage of her salary. Like 60% is through the university, 40% is through the hospital. So her contract is a little different than mine, but she was the one who kind of gave me the idea that this was doable.
Right.
I think it's worth noting that it is imperative that our nurse practitioner faculty practice in order to maintain their certification. I had 2 faculty members who had to they were strictly undergraduate. They weren't teaching in the DNP program, but they gave up their nurse practitioner because they couldn't balance all that together. They had kids, they had different things. They couldn't balance it, and they gave it up. And I've always felt it was such a shame, and tried to find ways to make it work for them because they earned it and they needed, but it's an imperative. It is not just a nice thing to do practice, because in order to maintain your nurse practitioner and be able to teach, you have to have it. And so there's that pressure to do that also.
So again, I teach leadership in the senior year, and I consider that a little bit of, the polishing and finishing school of nurses. And how do we, launch these brand new nurses into the workforce to be collegial and, team players and reach out when they need help. And I know that I bring to them every single day that I'm in front of them some story about some way that we bonded together to get through a patient situation, or when I leaned on somebody else, because it turns out it's impossible to know everything, and it just sets up a different level of role model when you practice yourself. And, I hold my doctorate, so academically I'm Dr. Casey. But when I see them in the hospital, I'm like, guys, we're colleagues. You call me Lindsay here, right? And it just completely, I think, adds just such a different, dimension of where they are and where they can go. And, where they can go will look different than mine. And that's beautiful and wonderful, but we all get to work together. And I think that is just so important, to be that level of a role model for our students and show them that it is still you know, so important for me to keep up my clinical skills, and also because I love it. I love working with patients. I love working with my students. And I think that, you know, maybe that's something that I didn't realize as I went into teaching. You know, I knew I wanted to teach. I like teaching. I like explaining things, but I don't think I realized how much I was going to love the interactions with my students. And so I get to love my time with my students, and then I get to love my time with my patients, and I get to love some more time at home with my kids. So it's really fantastic. And I share all of that with them. I'm very candid. And I think that that helps, you know, with that rapport and that relationship that I have with the students. And they see how hard I'm working, and they meet me there too, which is beautiful.
So that leads into one of the questions that we were going to ask, and that was perfect segue, Lindsay. One of the questions we were going to ask is, what gives you joy in your faculty role? Why do you keep doing it? You know, what keeps you coming back? What keeps you doing it? Because it's not the pay. Let's just be honest. It's not the pay that's doing it. So what keeps you doing it? What is your joy?
So in my first semester, right? So a month from now, last year, there were some students that were struggling on a clinical site, and they had a little just disagreement with their clinical faculty, and didn't want to say anything because they were worried about repercussions. And, you know, I heard them out. And then another student came to me, and first of all, I am a brand new face to them. They don't know me from anywhere, but I was able within a few short weeks to create enough of a relationship and enough of a trust in me that I was somebody that they could reach out to. And I was able to empower the entire clinical group to speak in a professional, calm, collective, unified, polite manner to convey their needs. And they were able to just make this point to, you know, the general faculty who had been there for a little while. And they did it in such a, honestly, a mature and professional manner. And I'm like, oh my goodness, guys, like, you guys did amazing. And they came right back to well, that's because that's what we saw you do. That's how, you know, that's what we learned from you. That's what we took from you. It was your support. And I'm like, oh my gosh, like that ripple, right? That ripple. So they're going to turn and they're going to take that and they're going to pay that forward. Or the way that I taught them how to read EKGs, they're going to pay that forward. And, you know, all of the little nuances and the things that we teach them, it's just, I can affect my 15 patients in my clinic day, or I can affect their patients exponentially over. And oh my gosh, you know, how great can my impact on the world of nursing be? And I get that through teaching, which is, you know, just beyond amazing.
Thank you, Lindsay.
So as an NP, I had several students during the course of my years in practice, and I always wanted to eventually transition to education, and because I just felt like I had so much to give, and the students that I had enjoyed being with me as well. And I was like very, I guess, comfortable. So I was fearful of making that big change. And so my kids, I talked to them about going back to, they talked me into, yeah, Mom, go back to school. You can do this and get your doctorate and just do it. If that's really what you want to do it. And just seeing the light go on in these students and knowing that you had something to do with that, and that they're going to be the kind of nurse that you always, that you wanted to be and that you became, and knowing that the care is moving forward to the next generation. I mean, that's what really brings you back. I mean, it's just knowing that you're putting out a great product, a wonderful nurse who is going to be caring and compassionate, you know, and educated and knowledgeable about what's going on with their patient, and taking good care of them. Because if you've ever been sick and you've been in a situation where you have good nurses, you want to continue that. And, you know, so you've had family members be where you had to have nurses at your bedside and you've experienced that. You want to make sure that you continue to put those out there.
Sharon, I bet you have lots of stories to tell.
Did you say Sharon?
Yeah,
Sorry.
Sharon. Yeah.
Oh yes, tons of stories. It's interesting. My last clinical rotation, my students, I always have a million questions for them. And you know, I don't tell them the questions out of the week before. And they said to me the last day, they said one of the things about me is they would meet the day before and try to think of all questions that I might ask them and be prepared for it. And I said, that is the nicest thing that anyone has ever said to me. Because it's like you want to make sure that you're giving them everything that they need, and you know, for them to be inquisitive, and you know, for them, I love nursing. I've had a great career, and I love all the schooling that I've attended myself, as well as teaching others. So it's really been good for me, and I like to build that passion in them, because I think that, you know, the way nursing is gone, I think that the students that we're seeing, we're not seeing that passion anymore. We're not seeing them have joy. I had a fun time. Nursing was fun. Nurses are great people. They're smart. They're, you know, like to get together. They, you know, it's hard work. It's extremely hard work. So, you know, to take all of it together and try to put it to these kids that are coming up and keep them building on that so that they will continue, because we got to make some changes here. My studies for many of my degrees, lastly, my doctorate, was always looking at RN satisfaction, because that is one thing that I noticed as I went along, that nurses got less and less and less satisfied. And if you go out on the floors now, it's crazy. They are depressed. They are overwhelmed. They're all considering if this is what they should be doing for the rest of their lives. It's really difficult. We have to bring that passion back. And some of the things that I think have happened is that they're so removed from the bedside now that they don't actually get to make a connection with the patient. And that's one of the reasons that most people go into nursing, is because of that connection, you know, to meet people, to help people. So, you know, I always try to point out things like that to them, so that, you know, maybe they'll say, oh yeah, that could be why I did it. It wasn't because, you know, I was told they're going to make lots of money. They can do travel nurses where they pay billions of dollars in that role. So, you know, I think we have a lot of work to do, and it is very difficult, you know, looking at faculty in the colleges and, you know, hearing about all the things that, you know, it's not great pay. And why is that so? Why would someone in the teaching role be being paid less than, you know, other, you know, people at the bedside? You know, that you wouldn't have got there without these people. So, you know, we really have to look at healthcare in general and make some changes, and fast, because the workforce is diminishing rapidly. So we are in a real crisis here. And, you know, any input, I go on all these things, listen to what other people are doing. I find we're all beating our heads against the wall, trying to come up with new ideas, but all very important work.
Thanks, Sharon. So we'll close on the thought. You have a friend who's considering being a nursing faculty member. What would your advice be? What would you say to them? What would you give them? Information? What would you say about being a faculty member? And you probably do have people who are asking you that question, so maybe that's something you've thought about. I know, Bernice, you said you had a colleague and a mentor that kind of influenced you. Now you're the one that may be influencing someone. What would you say?
I would say that you definitely have to have a passion for it, because if you don't, then you will not be happy doing this, because the benefits do outweigh the work, only if you are in it for, not for the gratitude and the money. I mean, you have to have something inside of you that's a passion for you to want to do this. But if you do, then I think that it is, and I think that practice and education is a great kind of work balance. So you get kind of the best of both worlds. You don't give up one to have the other. And I think that is kind of where, I guess, the tire hits the road. And I would say if you can, work that out, that's the best way. But I definitely would welcome anybody who has the passion into education, but you have to go into it for all the right reasons.
You're not doing it for the money, as you say.
You have to do it because, right, of something else that's in you, some other passion that you have.
Yeah.
And not the accolades, not the money. It's really, yeah.
It's the joy stuff. It's seeing the light bulbs going on.
Definitely,
Having a student come back to you in a year or so after they've been out and telling you some wonderful thing that's happened or that's something they remembered. A quick story: when I graduated with my BS, it took me probably a year of good solid experience, but I wrote back to my dean and I told her, I said, I get it now. I know what you were trying to teach me. And hearing that when the student comes back and says, I get it. What this thing you shared with us has made a world of difference. What is that? There's no price you can put on it, Lindsay, do you have any last advice that you would give someone who's interested in being a faculty member?
I think you and Bernice really have summed it up. It's really, this has to be something that excites you day in and day out. And to Bernice's point, it excites me differently than my clinical practice. And I love how she, spoke of that practice and teaching balance, and that does work well for me because I get excited to go to both places of work for different reasons. And I really do think that I entered this because I want to keep pushing nursing forward and reminding all of the nursing students of how wonderful nursing really is, even though the nurses at the bedside are appearing so tired and worn out. And how do we keep taking good care of ourselves? And we do that by putting good, strong nurses out into the workforce who are excited and breathe new life into the clinical floors and everything every time they go to clinical and every time that we graduate a new batch. And I think that that's really just something that is so important for nurses to just keep supporting nurses. And this is another way that we can be doing this, is by just educating them.
Thank you, Lindsay. Diane, anything you want to close with?
No, I don't think so. I think one of the best compliments any of us can get is when a student comes back and just like you said, I got it. And most of that comes back in a form of, can you write me a reference letter? But I will take it. I just got one of those last week and said, I learned so much from you, not only for nursing, but in how to live my life and how to make some better decisions. And I thought, okay, not just teaching nursing, but life lessons. So
yeah,
love
fantastic.
that.
Fantastic. Thanks, Diane. Mm-hmm. Well, everyone, thank you so much for participating. We really, I think, had a good discussion group. And if nothing else, we walk away feeling positive about what we do. Mm-hmm. So that's the good thing. Diane, any closing?
No, thank you all. We appreciate you coming, spending an hour with us. And it was wonderful to talk about this with you. Thank you.
Thank you so much. Have a good rest of the day and good luck in the next semester.
Yeah, thank you so much.
Good luck. Take care.
Take care.
Bye-bye.